let's take a poll, because obviously we've heard from the experts here as far as what they would do for grade 1 degenerative spondylolisthesis. So if you had that patient, let's say you had a patient that had back pain 50%, leg pain 50%, they had some weakness, at 4-5, so they had some weakness with ankle dorsiflexion, had failed conservative options. How many of you would approach this by doing a lateral lumbar interbody fusion? Show of hands. Single level L4-5, unstable spondy.
Assuming good anatomy for any approach you want.
Okay, so we got quite a few, but at least half dozen. Who would do a TLIF? Okay, about the same number. Who would do a posterior stabilization? Interesting. What if it was a stable spondylolisthesis? There's absolutely no slip whatsoever comparing flexion to extension. Would that change anybody's opinion? Anyone from the panel here?
How old?
Let's say it's a 52-year-old.
That's sort of borderline.
How about from Rick?
My thought process is this.
Oh, can you speak into the microphone?
If this is an older patient, 60, 65, 70, and they have a completely stable grade 1 spondylolisthesis, I'll just do a decompression of stenosis, minimally invasive. If they're 40 years old, I'll reduce it and do a fusion because they are going to become unstable at some point in the future. So your age 52 is sort of in the middle there, and I would probably try the decompression and warn them that they may have to come back for a fusion.
What if it was a 45-year-old patient with an unstable spondy with like 90% leg pain? What would you do then?
Fusion.
You would?
Yeah.
So Roger Hartle is, he's going to be, I guess, awarded some sort of award from the CNS about, he did, I think they did a meta-analysis of patients who actually had just decompressions alone for spondylolisthesis, and it turns out a fair number of these patients do very well, and the results seem to be durable. So I'm not sure if
this paper specifically pointed out that they were stable spondies, though.
They were stable
not
spondies?
unstable.
Okay, got it.
Curious for the guys that are doing lateral surgery for this type of case, because what if a patient has a tall disc and primarily central stenosis in that grade 1 spondy? You still think you can address that laterally? I mean, because I feel like for something like that, you have to go unless you can really get great reduction, really have lateral stenosis.
So I do a lot of direct decompressions in addition to the indirect. So for that patient, I would do a LLIF, and then on percutaneously, posteriorly, I would do perc screws into an 18-millimeter tube. I would do like a laminoplasty. Yeah, so I'm pretty quick to put a tube down there because it doesn't take very long to do a laminoplasty, decompression, and then I leave the OR. I know I took care of that problem. It's 100% open.
So the advantage there of the lateral is solely the lateral interbody is just going to give you that much better fusion.
Correct. So the lateral's for the fusion, right? That's why I'm using that. And it's a quick procedure. I think if you do it well and you get a lot of experience doing it, I think you get good results with low complication rates. So to me, for L4-5 even, probably 95% of my L4-5s are an LLIF. And I just, once in a while, see them. I told you the reason why I won't do it. If their nerve anatomy is such, I won't do it. But probably over 90% of, or at least 90% of the LLIFs in general I do are 4-5, right? That's where the pathology is. So I hear a lot of people who are concerned about that procedure, L4-5. I just don't see that as an issue.
So let's just kind of turn this around, because Dr. Brett had the option. Dr. Brett is the patient, yeah, right? Other than the fact that his condition was stable, he had stenosis, and he elected for dynamic stabilization, and apparently you're doing well, correct?
Yeah, I think if it was a patient who was, I think the median age in the Coflex study was 62. So let's say, and I was 60 when I had my surgery. So let's say it's a 62-year-old patient with a grade 1 spondylolisthesis who has a disc-based collapse and foraminal collapse. I would do a TLIF on that patient. In my case, disc height's preserved. I've got some disc bulging, but no herniation. I have a complete block when I'm standing on my myelogram. So I do a decompressive laminectomy, and then in my case, I chose to have Coflex because I didn't want to have another surgery. I didn't, I knew there would be a 10 to 15% chance over 2 years that I would come back. with just a straight decompression and have either a spondy develop or recurrent facet hypertrophy and lateral recess narrowing, need to have another operation. So I chose to have the Coflex because I didn't want to have surgery to begin with, and I didn't want to have to come back. So with the data that I looked at 3 years ago, that's what I had to look at. And I think now things are sort of seem to be proving that the risk of recurrence or reoperation is less with Coflex compared to straight decompression in a case like mine. And the results are better in terms of relief of pain with the Oswestry and VAS scores. So I think I made the right decision, and I would do it again if I had to.
So let's kind of turn this around on us again, because I've seen several surveys that ask specifically to surgeons, if this was you, what would you have done on you? Okay, so we're not talking about your patient anymore. This is you. So you're like Daryl. You had intractable back pain. Let's say you had radiculopathy, and you had an unstable spondylolisthesis at L4-5. Okay, and then you've tried all the conservative options. You failed it. What would you do? So I'm going to give you 4 options, and everybody has to vote, at least the surgeons in here, okay? So one is LLIF with percutaneous posterior.
Sorry, unstable meaning movement on flexion extension.
Yes, 4 millimeters of translation comparing flexion to extension. This is your x-ray, okay? And it shows like moderate to severe stenosis. Number 2 is a unilateral TLIF, okay, percutaneous or otherwise. Number 3 is posterior decompression, hemilaminectomy with dynamic stabilization, and number 4 is just decompression. What would you have done? Okay, so everyone has to vote. We got to get this.
But Jeff, you leave out like what, and I'm not advocating for it, but why not a posterior laminectomy and post-lateral fusion? Why not an ALIF? Why not a midline cortical screw and PLIF? I mean, so there's still a spectrum inside of that. So, this case for me is an MIS TLIF. This I do in a surgery center, and they go home. I think it's anesthesia more than technique in a lot of these things. But I think that we're too dismissive of things that work. We're saying direct decompression, and I do buy that what Dr. Stone and everyone is saying about interbody fusion at 4-5. I think that if you look at the market, this is my sense. Mm-hmm. I could be completely wrong. If you look at an MIS TLIF, the market was shifting tremendously to an MIS TLIF, and a lot of pseudos happened, end plate preparations. People got the technique but never overcame that. Not to think for everybody, but a lateral interbody fusion is a much more predictable fusion and allows you to address it. So then you see the market shifting, at least what I see in our area on the ortho side. The market is shifting now. Guys they want some kind of, marketing hype, maybe sexiness of an MIS, and they're going midline cortical screw and a bilateral PLIF. And I see very good fusions with that as well. And I think we kind of pendulum swung. Expert guys who do lateral all the time, 4-5 is not a challenge. I think you do it 15, 20 minutes. But, I see a lot of bad lateral that happens out there. And it's access. And even in our own institution, we see lateral complications. Renal complications, renal biopsies, unintentionally death happens at expert guys who are doing it as well.
No question.
So I think that lateral is something, if you look at the white paper analysis by William Blair and looking at the financial analysis, 25% of surgeons, 1 in 4, have done lateral. 12% of surgeons actively use lateral in their practice, meaning that it's more than 2 or 3 times per month. That's still a small market share. So when you talk to lateral surgeons and novice people, there's still a tremendous adoption concern, and that is anesthetic concern, positioning concern, all the imaging concerns, everything else that goes along with it. And I think in these cases, and I see my partner's cases, traditional open laminectomy, post-lateral fusion does pretty well also.
What would you choose then of those choices that you just mentioned then?
I'm going to pay $150,000 and fly to Korea and have Dr. Kim do a posterior endoscopic laminectomy. That's what I'm going to do.
That's really great. So let's just recategorize this then, okay? Let's say I'm still going to keep those 4 categories, but under the option 2, it could be a PLIF, it could be a TLIF, it could be bilateral, unilateral. It doesn't matter. I'm just saying posterior approach with interbody and screws then, okay? And how you skin that cat, it doesn't really matter. ALIF, I just don't, this is ALIF right now. I'll keep that one out just so we don't bias ourselves. So if this was you, how many of you would have a lateral and then percutaneous posterior screws?
Jeff, how about only, would you place an A-leaf or lateral?
Would we do an A-LIF or laterally? Yes, so let's classify the O-lifts and the L-lifts together as one. And in fact, you could just put A-LIF in that category too, because in reality, an O-LIF at L5S1 is really an A-LIF, right? Let's just be honest about that. So all those sort of categories, the A-LIF, O-LIF, and L-LIF, would you have that with posterior perc screws? How many of you would have that approach? Okay. How many of you would have posterior approach, meaning either a TLIF, a PLIF, it could be regular perc screws or cortical screws? How many of you guys would go for that approach? See, that's fair. How many of you would go for posterior dynamic stabilization and decompression? And then how many of you guys would go for just a decompression alone, if it was you? Wow, that's really...
Chiropractic.
Sorry?
Chiropractic.
No, this is assuming that you failed, actually, you know? So you failed the chiropractic. That's really interesting that the majority of the people would choose like a posterior base approach. That's really, really fascinating, actually. Daryl, comments? Because you chose something that...
Well,
you even elected something that...
Well, you said it was
you were stable.
unstable. Yeah, I was stable. I didn't have any spondy. And a patient who's still stable but has a few millimeters of spondy, those are patients that I might do a interlaminar stabilization on after a decompressive laminectomy. And it's in my practice, about 20% of those type of patients end up having that. But in a case where there's spinal stenosis and foraminal narrowing, and you've got a grade 1 or more spondylolisthesis that's moving on flexion extension films, I'd always in my practice, do a TLIF on those patients and I do it open with pedicle screws and a TLIF peak cage.
Rick, can you give us a little bit of historical perspective here? Because like what Dr. Singh just mentioned, it's totally true, right? Like, it's like TLIF, and then people get excited about the lateral, and then so it's this pendulum swinging. So how do you make sense of all this as far as like, is it best to do a PLIF, which is a little bit more medial, or a TLIF, which is a little bit more lateral, and the craze with the laterals? I mean, how do you make sense of all this?
I think almost all of these procedures will work well. And there are other reasons to choose one over the other. I specifically chose TLIF because I can do that in about 90 minutes. I don't have to change positions. So it's a faster operation for me, and I'll get the same job done, especially with the new cage that I showed you that kind of circles around and gives you a huge coverage of your end plate. That's one of the limitations of that. But other than open laminectomy and posterior transverse process fusion, which I disagree with Kern on, I think that's kind of fallen below standard of care. I haven't done one of those since 2000.
I haven't seen one of those for a long time
I
either.
think we've demonstrated the interbody techniques are just vastly superior, so I would never choose to do that.
So do you think that the advent of the expandable cages will change sort of the way that to bring that pendulum sort of back to posterior approaches?
No. I think lateral is going to continue to be used, especially for scoliosis. I think it'll be used less for routine degenerative disease. I think that's going to stay relatively posterior. Simply because it's easier and you don't have to worry about abdominal structures. And in most people's hands, abdominal complications are fearful. If you don't do this all the time, I mean, as Kern said, even in the best of hands, you can have complications like kidney biopsies. If you've had a peritonitis and your kidney stuck to your retroperitoneum and it won't move, that actually can happen pretty easily if you're over a 2-3 or 1-2.
Dr. Stone, what are your thoughts on why direct lateral versus an OLIF?
Well, for an OLIF, I'd be concerned about the vasculature. For me, I prefer an LLIF. And so if I have a case where I'd consider an OLIF, I'd probably do a TLIF instead. Yeah. But for me, regarding a spondylolisthesis, is it stable or not stable? To me, a lot of these, it comes down to the facet joints. So I focus on the facets. And if the facets are overgrown and truly autofused, even if you have a spondylolisthesis, maybe 5 millimeters, if there's no translation at all comparing supine imaging flexion films to supine imaging films, to me it's stable, and that's not going to become unstable with time. So even if someone's young, I would still do a decompression only and not a fusion if their facets are overgrown and basically auto-fused. So I tend to lean towards decompressions for a lot of my patients. The only time I'll do a fusion is when there's clearly a mobile spondylolisthesis and I feel that's contributing a lot to their symptoms, then obviously I want to stabilize that.
Kern?
So, I'll tell you this, 5 years from now, I think that, I'll tell you the number one driver for decision-making on this will be cost. And so, I run 2 surgery centers, and I told you this case, lateral, ALIF, TLIF, I do outpatient in the surgery center. And if you want to see physician behavior change, is when you go to a global fee payment, and you are now directly responsible for that. That changes grafts, biologics, instrumentation, everything changes. So to dismiss decompression, post-lateral fusion, all these things we say, because right now we're economically immune to it. But as we start risk or profit sharing with a hospital or an ASC entity, et cetera, those tremendously change physician behaviors. And so you should ask this question again in 5 years.
So in 5 years, if we're in that type of economic environment, everything's bundled, right? So what would you do if this is your surgery center and you want to try to minimize the costs and try to use as little implant as you possibly can, and also allow for the patient to have maximum clinical outcome benefits? What would you do? How would you?
So actually, I like in some ways I like lateral depending upon the biologic you put in. Depending if you put unilateral fixation, that's savings. It depends upon your cost driver. So for me now. I was talking to Shiraz. We talked about this together. We've been looking at this. But, I started taking iliac crests about 2 years ago. Sounds crazy, but percutaneous iliac crest. Not a little scrape, but actually a DACA tube and scrape out 40 cc's. And patients don't know it, and you send them home. And so there's no biologic. Our biggest driver was biologic. Whether you want to use osteoamp, BMP, allograft, whatever it is, it's a major cost driver. The second was negotiating. When you look at interbody costs, so lateral, I love lateral. I do a lot of lateral, especially for degen scolies and stuff like that. But the lateral, I hate to say, the NuVa guys are in here. NuVa is the smartest spine company in the market, and I'll tell you why. I have no conflicts of interest with NuVa, because look at how they bundle disposables. The light cord is bundled with one. You may ask for a scalpel knife that's bundled separate disposable. By the time you calculate it out, they're disposable almost as much, if not greater than the inner body. So when I was going through this and negotiating the inner body cost out, and I was saying, we don't need a knife, we don't need a light handle, we don't need this. Their SKUs and their inventories are so confusing, you can't separate it out. And so finally I had to get down. What's going to happen, I believe, and I'm not saying that necessarily going to be happening quickly, but it'll go to single level construct. You can do whatever you want to do, but you're paid for a single level construct. Whatever that may be for a single level lumbar fusion. However you want to do it the most efficiently, you will get paid X amount on that. And I think biologics is the easiest correctable thing, and then selective instrumentation, unilateral or not, and selective decompression is probably the next kind of variables on that cost chain.
So again, for this patient, then what would you do though? Are you saying that you would do a lateral and then just unilateral screws?
Well, I mean, this one is a little bit, kind of gray in this area on this. And I'm actually not against an interspinous process device, actually, in some of these situations. Because if you look at, the problem with how we look at cost is we look at direct costs. We were talking about this. The insurer only cares about the 1 year and the reoperation. They don't care after that. So I look at it as my own cost to it. And so I think decompression with selective device is not unreasonable in that. I also think interbody and lateral with a unilateral fixation is actually not unreasonable. I think it's how you negotiate your implant cost to that point.
So you made a comment that you would actually fly over to South Korea to have Dr. Kim do your surgery, right? But actually, it turns out that some of the surgeons there are actually doing endoscopic fusions now. So Dr. Kim, can you sort of talk about this just a little bit as far as how the surgeons are utilizing an endoscope in order to perform a fusion?
Yeah, let me have a brief talk about the endoscope base, TLIF, especially the TLIF concept. If you search the article, you can find out the two important articles about the endoscope-based TLIF procedures. I remember 2005, there's a endoscope-based spacer. We called it the between cage, invented by Israel. And many Korean surgeons, they experienced about the between cage insertion after endoscopic discectomy, endoscopic preparation, and they put the between cage using the autobahn and allograft insertion, and then put the pedicle screw over there. And the other article is the Michael Wang, Miami University. He last year he published one article in JNS. I remember neurological focus, endoscopic discectomy preparation, and the OPESH, some Optimus, right, Optimus, and they inserted a BMP, and they put the percutaneous pedicle screw. But Michael described the drawback of that kind of his surgical techniques. One of the most important drawbacks or this limitation in his technique is that it's not easy to direct decompression, foraminal decompression, laminotomy, and fastectomy at all. So in Korea we have a very strict indication of the fusion surgery. So if there is no serious severe spinal stenosis, severe foraminal stenosis, the government couldn't support any reimbursement. So that is why some Korean doctors they started endoscopic laminotomy and foraminotomy and fastectomy, and they started insert the cage. This cage is very simple, commonly used as cage. But you saw my surgical techniques. That is a single portal, monoportal. But if we adopt the biportal, one is the endoscope itself. The other is the working the portal. So through the kind of the uniportal guided biportal procedures, just very similar surgical skills we can get. So just like the open surgery, just like the tubular surgery. So that is why it is accessible to insert the endoscope fusion under the endoscope guided. We can draw out most of the lamina and facet, and can the very gentle preparation of an endoplate, and then cage insertion. If we have an expandable cage, we can get a fantastic result. So you can read one very interesting paper next August. The one paper, endoscopic biportal TLIF procedures, will be published in Neurology Focus next month. So anyway, that is one of the prototype of the full endoscope basis lumbar interval fusion. So, but I don't know, it is real valuable than the other tubular-based TLIF procedures or not. Anyway, interesting.
Thank you very much. I've always sort of wondered why it is here in the United States that we're not adopting endoscopic like we did with tube-based. And it obviously took us a little while to actually say, yes, tube-based surgeries, MIS, is the right way to go. But if you see what's happening in Europe and what's happening in Asia, I mean, it's got to catch up. And I do believe that this biportal technique, I really do believe that that's going to be a potential game changer, Any other questions out there for our panelists? If not, let's give them a round of applause.